Hello, afternoon.
Good afternoon. Have a seat, please. Who did you see just now?
I've just seen Mr. Ro Ghazali Awang Kecil.
And you had no problems taking the history and examining him?
No problem.
Okay, what is your name and index number?
My name is Alwi. My
Okay.
index number is AM 50832.
Okay.
Okay, tell us the history of your patient.
Okay, well, I've just seen Mr. Ro Ghazali Awang Kecil. He is a 57-year-old Malay gentleman from Kota Baru. He lives at his own home with his wife and 2 children, and he is independent with all activities of daily livings prior to this presentation. He was admitted yesterday with complaint of 5 days history of progressive shortness of breath associated with orthopnea and paroxysmal nocturnal dyspnea, as well as cough productive of white froth disputum, which is in keeping with left ventricular failure. He denied any fever, chest pain, or hemoptysis. He has a background history of ischemic heart disease, which was first diagnosed in the year 2000 when he first presented with sudden onset of chest pain and shortness of breath on exertion. ECG and echo at that time done, and he said that he was told to have ischemic heart disease and he was treated medically. In late 2006, he had a major ischemic event which led him to have a coronary angiogram done at HUKM. The angiogram showed that he had severe 2-vessel disease and valvular lesion as well. He was offered for operative intervention but refused for bypass as well as valve replacement. And he opted for medical therapy as well as traditional medication. In 2007, he mentioned that he had multiple admission to the hospital, and from his description, it sounds like he has a multiple admission due to acute coronary syndrome. He remained symptoms-free throughout 2008 until now. Prior to this presentation, he denied any problem with effort tolerance. He still managed to do all his activity at home as well as at workplace. His other medical problems include number 2, type 2 diabetes, which was diagnosed about 12 months ago with incidental finding of elevated blood sugar level with a reading of 30 millimole per liter. He denied any symptoms of polyuria or polydipsia at that time, and because of that, he was started on oral hypoglycemic agent at that time, and the insulin therapy was started about 7 months ago on top of the oral hypoglycemic agent. He is doing self-monitoring of blood sugar level at home, and his blood sugar range between 6.9 to 10 with maximum around 15. He denies any incidence of hypoglycemia or any previous admission because of complication from hyperglycemia. He claims adherence to medication, to medical therapy, but claim not to comply to dietary modification. He had a stroke as well in June 2007, in which he presented with expressive aphasia. He was started on warfarin from that day. His aphasia fortunately resolved a few weeks later. He also had hypertension, which was diagnosed about 10 years ago and was started on oral antihypertensive therapy. He also had a chronic obstructive lung disease of last 5 years based on the fact that he's been using a bronchodilator of Conbivan on the PRN basis. He's also a heavy smoker, smoked since the age of 9 years old until now. He smoked in total of 48 pack years, and currently he has no intention of stop smoking. He is on multiple medication, and his medication include glycoside 160 milligrams twice a day, metformin slow release 1700 milligrams and 850 milligrams at night. He's on ramipril 2.5 milligrams daily, digoxin 0.25 milligrams daily, arcabose 100 milligrams TDS, Plavix 75 milligrams daily, atorvastatin 20 milligrams daily, metoprolol 25 milligrams twice a day, furosemide 40 milligrams daily, sublingual GTN as needed, spironolactone 50 milligrams BD, bisulfan 8 milligrams TDS, and subcutaneous glargine 16 unit on night, as well as warfarin. The dose he's not very sure at that time. He's also allergic to aspirin in in the year 2000, in which he developed urticaria rash upon taking aspirin. However, he was subjected for desensitization therapy and claimed to be able to tolerate aspirin after the desensitization therapy. On the social history, he is married with 5 children, 2 sons and 3 daughters. He has a very good family support and good relationship with all members in the family. He's able to mobilize independently and able to drive to hospital to seek treatment and also for regular medical follow-up. He's very committed to his work and currently conducting his own business since 1993 and still actively working even on the day of his first presentation with this problem. On examination.
Let's just stop there for a minute before we listen to your physical finding. Clarify a few points about the history. You said that this current admission is due to symptoms in keeping with left ventricular failure.
That's right. Yeah. Yes.
Would there be any differential diagnosis based on the history?
Yes. His history is strongly suggestive of left ventricular failure in view of shortness of breath, paroxysmal nocturnal dyspnea, and orthopnea. The differential diagnosis include the exacerbation of chronic lung disease or chronic obstructive airways disease, and pulmonary embolism can also be among the differential diagnoses. However, there are also many other differential diagnoses that can be considered, pericardial effusion, for example, and community-acquired pneumonia.
Were you able to identify any sort of precipitating factors for the left ventricular failure that seems to be the primary diagnosis?
At the moment, he denied the presence of ischemic chest pain currently, and there is also no sign of no symptom to suggest any evidence of infection to suggest.
But the absence of chest pain exclude
absence of chest pain in the patient. Absence does not exclude the presence of myocardial ischemia because especially the patient is diabetic and have multiple risk factors for ischemic heart disease. So the absence of chest pain does not exclude it, but the presence of chest pain make the acute coronary syndrome will be more likely. However, I still think at this point that the acute coronary syndrome is the most likely precipitant for his left ventricular failure.
He's on warfarin since his cerebrovascular accident a couple of years ago, is that right?
Yes.
And how often is he having his warfarin monitored?
He has his blood taken every 2 weeks, according to the patient.
Even now, every 2 weeks?
Every 2 weeks. He comes to the hospital for blood taking. It could be for different reasons because he's also diabetic and he has a multiple clinic follow-up. But he said that he come to hospital almost every 2 weeks to have his blood taken.
But not necessarily for...
May not necessarily for monitoring, yes.
And do you have a sense of whether in fact control is adequate from the history? Is there any history of over or anticoagulation?
Yes. From there is no history of over anticoagulation. The patient have never complained of any bruises or any bleeding tendencies. However, it's difficult to ascertain whether the patient achieve adequate therapeutic level or not.
He doesn't carry a book. He's not shown you his INR book.
I did not ask for his INR book. Yeah.
Right. Okay. Tell us the examination findings now, but concentrating on the relevant positive and negative
findings.
points.
Yeah. Okay. The patient on examination, the patient appeared comfortable, alert orientated, and not tachypneic. Patient still on 2 liters per minute oxygen via nasoprong. The patient currently afebrile, and the BP 140/100, pulse rate 62 beats per minute, irregular, with good volume.
Sorry, what is the pulse rate again?
62 beats per minute.
Okay. Yeah.
Okay. And the patient have marked nicotine stain over his fingernail, but no clubbing, and JVP. Patient is not pale and JVP not elevated, and cardiovascular examination revealed a displaced apex beat to 7 intercostal space mid-clavicular line. His heart sounds dual with irregular heartbeat, however no murmur appreciated, and respiratory examination revealed hyperinflated lungs with generalized and inspiratory and expiratory rhonchi with cause crepitation of a left lower zone. Abdominal examination revealed a soft, non-tender abdomen. The liver palpable around 3 finger breadth with total span of 15 centimeter, which probably suggestive of a toast liver, and the liver was not pulsatile.
So you see the liver was 15
15 centimeter span.
Span.
Yes. And the patient have no pedal edema. Dorsal pedis were both palpable. Neurological examination was grossly intact. There was no focal weaknesses, no evidence of peripheral sensory neuropathy, and fundoscopic examination is difficult to visualize because of the immature cataract on both sides.
Any vascular bruise?
No carotid bruit.
You mentioned that the apex speed is at the 7th intercostal
Yes.
speed, a mid-clavicular line.
Yes. Yeah. So
I mean, do you, what is your comment on that?
So the apex speed is displaced but more inferiorly instead of infralaterally. So
You expect more of infralateral.
usually the apex speed displays more infralaterally, but in his case it's actually displaced more inferiorly. And I would say that this is a combination of a cardiomegaly secondary to ischemic dilated cardiomyopathy, with possibility of it actually being pushed down by a hyperinflated lungs.
Okay. Have you got any more
Okay.
findings?
Yeah. In summary,
Yeah.
this 57-year-old Malay gentleman presented with 5 days history of progressive shortness of breath, typical of left ventricular failure, most likely precipitated by an unstable angina, in view of multiple risk factors for acute coronary syndrome. His other important problems which need to be addressed include ischemic heart disease complicated with ischemic dilated cardiomyopathy, and previous investigation revealed a severe two-vessel disease which require revascularization, in which the patient refused, and the patient still refused for operative intervention even at this moment. And the other problem is the chronic obstructive airways disease, currently exacerbated by the left ventricular failure. There was no evidence of infection, and currently the patient is not in respiratory distress. However, there is still clinical evidence of significant airway obstruction. And the third problem is the patient type 2 diabetes, with evidence of macrovascular complication, but so far no evidence of microvascular complication as yet. Blood sugar level, according to the patient's description, not optimally controlled, and the patient have no history of acute hyperglycemic complications so far. And number 4 is hypertension, BP currently not optimally achieving the target. We need to aim for his BP of below 130 over 80, and perhaps lower than 125 or 75 if there is evidence of proteinuria. The patient also in state of atrial fibrillation. However, the rate is currently controlled. And the other significant problem is cerebrovascular disease with previous history of stroke. However, currently no evidence of significant neurological deficit. In managing this patient,
let's just stop for a minute. You saw the patient how long after he was admitted? Just about a day?
No, but more than 24 hours after he was admitted.
More than a day. He was obviously better.
That's right, yes.
Compared to the state he was in when he was admitted.
That's right, yeah.
So let's just talk about his initial management, because you didn't see him when he first came in.
I know, I didn't see when he was came in.
Assuming you were the registrar on court for that night,
Mhm.
and he was brought in with the symptoms and the findings that you described to us,
Mhm.
how would you manage him then?
When he first presented in acute left ventricular failure, I would first put him in a 45 degrees position, put him on oxygen. In view of he has underlying chronic lung disease, his oxygen need to be given in a controlled manner, and put him on continuous SPO monitoring as well as on cardiac monitoring, and to get an IV access, and to give him furosemide, intravenous furosemide, between 40 to 60 milligram stat, and put on for CBD as well, to facilitate the urine output, and to give him intravenous morphine, 2.5 milligram stat, with intravenous antiemetic Maxilon, 10 milligrams, and if the BP is stable, and I would like to start him on intravenous isocat or nitrates, probably start at around 1 milligrams per hour, and with monitoring of the blood pressure, and with anticipating or suspecting that the patient might have acute coronary syndrome as the precipitant of this left ventricular failure, I would start the patient on acute dose of aspirin, 150 milligrams.
Would you straight away start the patient on aspirin, or is there anything that you would like to do first? You mentioned the acute coronary syndrome.
Okay, I would like to do ECG first and see if there's any ST segment changes.
Mhm.
And yes, I would like to do definitely get an ECG
Do
for
we
this
have
patient.
ECG? Maybe we can have a look at the ECG and tell us your comments on the. This is ECG when he was admitted that night.
Okay, this is an ECG of Mr. Roghazali on the day when he was admitted, and this ECG on the rhythm strip showed an atrial fibrillation with a rate of 75 beats per minute, between 75 beats per minute to 100 beats per minute, and there is poor Alwi progression on precordial leads, and there is slight ST segment depression in V5 and V6 around 0.5 millimeter. Otherwise, there is no other changes. I would like to compare this ECG with his old ECG.
So, what does the current ECG show?
So current
does it support?
ECG,
Yeah.
current ECG shows that patient is in atrial fibrillation and also ST segment depression in the lateral leads V5 to V6.
So what does that mean?
So
What
this
does that mean?
this suggestive of lateral. If this is a new changes, then this is suggestive of lateral ischemia, which is consistent with acute coronary syndrome as the precipitant of his current left ventricular failure.
Okay. What other investigations would you order that night?
I would like also to have chest X-ray.
Okay. I think you have a chest X-ray as well, right? We don't have the X-ray box, but I think we can
Okay.
look against the light and tell us whether there are any gross changes.
This is the X-ray of Roghazali taken on the day of admission. Okay, this X-rays, which is portable and AP film, which is not optimal, but considering it's in emergency, so it shows cardiomegaly and also upper lobe diversion. And however, I can't see the cosophrenic angle to appreciate possibility of small pericardial effusion.
Pericardial?
To the pleural effusion, and however there is no obvious segmental consolidation. However, the presence of consolidative changes cannot be ruled out in the presence of failure. So we need to repeat the chest X-ray once the failure resolved to rule out any underlying infection.
Okay. Quickly now, any other investigations on that night?
Okay, and would like to do the very simple urine dipstick to look for any presence of proteinuria, and we also would like to do the baseline blood test, full blood count, to look for the white cell, any evidence of infection, anemia, FBC, and then do the renal function test, look for urea creatinine and liver function test as well, and more importantly, to look for cardiac biomarker for troponin T. Yes, for the troponin T.
All right. So when you saw him, he's obviously a lot better than compared
Yes.
to what he was in when he was first admitted. So you said you've listed the some of the problems that you have to attend to, and how are you going to sort out all these problems? You've given a list of his problems. Tell us quickly how you're going to sort them out, what you're going to do.
Yes, well, this gentleman have multiple medical problems, and we need to prioritize which one is the most important, and that's need to be addressed first. So in this gentleman, the most important problem that he's having is the severe ischemic heart disease, with currently possible acute coronary syndrome, with complicated by the acute left ventricular failure. This need to be addressed first with the optimal medical therapy acutely. So he need to be on double antiplatelet. He need to be on anticoagulation.
So, you've given a list of his medications. Do you think his medical treatment for his coronary artery disease is optimum at the moment? Is there...
Currently, he is on.
Or is there room for improvement?
Yes. At the moment, he's on reasonable list of medication. However, the dose is not yet optimum for many of his of the drug for the ischemic heart disease. For example, he's on ramipril 2.5 milligrams daily. We ideally we need to achieve 10 milligrams daily of ramipril. He is on metoprolol 25 milligrams BD. So this is also suboptimum. However, in view of his having the possibility of chronic obstructive airways disease, the beta blockers need to be reconsidered here. And so number of the drugs could still be optimized in terms of dosage.
Okay, so you said that he was once offered revascularization. Yeah?
Yes.
Is that an option now at the moment?
At the moment, he is at very high risk of adverse cardiac event without revascularization therapy because of currently he presented with acute coronary syndrome complicated with the cardiac failure. So I think at the moment he definitely need to be offered again for the revascularization therapy to reduce the risk of adverse cardiac outcome in the future.
Okay, yes. As you mentioned, he seems to be on quite a long list of medication.
Mm-hmm.
Can you also comment on the other drugs that he is on, apart from those for the coronary artery disease?
Okay, he's also on a number of oral hypoglycemic agents. He's on glucoside, metformin, acarbose, as well as insulin. So he is on multiple oral hypoglycemic agent with insulin. Ideally, insulin is the best therapy for diabetes, and if it's agreeable, he should be on basal bolus regimen. That is the best way to control the blood sugar level.
What type of insulin is he on now?
He's on subcutaneous glargine, 16 unit at night, which is a long-acting insulin with peakless, long-acting peakless insulin, which is very good because it provides a basal insulin level in the body over 24 hours.
Are you aware of any other potential advantages of this glargine compared to the other long-acting insulin?
Because the major advantages of glargine is because of its being peakless, it's less likely to cause hypoglycemia compared to other form of long-acting insulin.
Okay, yes. What about the other drugs?
The drugs for diabetes or other drugs?
He's also on digoxin, spironolactone.
Yes.
Could you think of any possible drug interaction between this? I think it's probably 10, if not more. Here.
That's right. Yeah, being on multiple medication or polypharmacy is definitely at risk of drug interaction. And as you can see here, it's on digoxin as well as metoprolol. So this is potentially can lead to bradycardia and may at risk of heart block as well. And he's been having chronic obstructive airways disease. Metoprolol can potentially worsen the chronic airway disease as well.
Right. What about the usage of digoxin? Any special precaution that you would take?
Digoxin, in using the digoxin, we need to make sure the serum potassium level is always above 4, preferably, or at least above a normal level. So the patient in digoxin, and however, the patient also on spironolactone. So this and also with ramipril, spironolactone and ramipril, we would expect to push the potassium level on the high side, which would probably make us a bit more comfortable that the patient being on digoxin, despite being on furosemide.
You have to be somewhat more extra careful there. So taking into consideration the patient's profile and list of medical problems, what would be your therapeutic strategy be? What would be your goals in managing him?
In managing him, the goal is definitely for improvement of quality of life. That is the number one goal. and because he has a multiple medical problem, and obviously treating him with medication may potentially lead to complication and reduction in quality of life. So we have to balance between quality of life and increased life expectancy.
Can you be a bit more specific in terms of, we're talking about therapeutic targets here?
Yes. So to being more specific, as we mentioned, his number one problem is ischemic heart disease. So first of all, we need to evaluate what is his symptoms prior to this presentation. So the aim is to reduce the symptoms with the medical therapy, with the maximization of medical therapy. Number two is we need to assess the risk of adverse cardiac outcome based on these multiple risk factors. So he's having severe ischemic heart disease with multiple vessel stenosis, then he need to be offered for revascularization to reduce the risk of cardiac event in the future.
Okay. What about his other medical problems? Do you think that sort of managing the vascular disease on its own is adequate? The coronary artery disease.
Sorry,
are there any other aspects of his medical, illnesses that may also affect the coronary artery disease progression?
Yes. His other medical problem, for example, diabetes, will affect the progression.
So what would be your goal in treating the diabetes, for example?
The goal for treating his diabetes is to reduce the hypoglycemic complication, as well as to prevent hypoglycemia, and also to reduce the risk of progression of coronary artery disease.
Any specific target?
However, in an established coronary artery disease, the blood sugar control is not we are not targeting as tight as patients without the established coronary artery disease based on the CORD study.
Do you just go by the blood sugar level, is it?
We go by the blood sugar level, HbA1c.
Right. Okay. So what sort of HbA1c?
Yeah. So in this group, the HbA1c is target around 7.5.
7.5.
Yeah. In a patient without established coronary artery disease, we wanted to achieve HbA1c normal, which is less than 6.
But for him, you wanted the HbA1c?
For him, HbA1c around 7 or 7.5 is actually acceptable in view of his already having an established coronary artery disease.
Okay. What about his lipid control?
Okay, his lipid control, for him having ischemic heart disease as well as diabetes type 2, we need to achieve lipid level LDL of less than 1.8.
Okay.
And the HDL of more than 1.0.
How do you come by all these figures? I mean, what is it based on? LDL of 1.8, for example?
Based on previous studies.
Yeah. Can you be a bit more specific? You have any guidelines or?
And also based on the Malaysian guideline for based on Malaysian guideline.
Okay.
In diabetic for achieving LDL, HDL level.
Okay, fine. So overall, what do you think is the long-term outcome or prognosis for this patient?
I think this patient, in view of this multiple medical problem, and he's also not very keen for invasive intervention, and also he's also not very keen for stopping smoking at the moment, and not very wanted to comply with the dietary modification for diabetes. I think the long-term prognosis is not very good. It's not going to be very good. So this need to be discussed with the patient and family members, and we need to ask the patient what is the patient's wish, and work with the patient and family members in terms of achieving the goal.
Would there be any specific focus or areas that you would counsel the patient before he is being discharged?
Okay. First of all, the patient, I would like to emphasize the patient to comply to the medication. And number two, the patient should strongly be advised to stop smoking. and subsequently we need also to advise to adopt a lifestyle modification in terms of to increase to reduce for dietary modification, reduce
It hasn't
Fat
been that
intake.
successful, I suppose, so
Yeah.
far.
And also of course to gradually increase the exercise capacity.
Thumbs up.
Okay, thanks. Okay, I think we can stop there. Okay,
Thank you very much.
we can go now.